Welcome back. We are in Module 5, Medication Use Process Part 2, to finish off the series on medication management in patients with advanced illness. My name is Dr. Nikki Brandt. I am accompanied by Dr. Lynn McPherson and Dr. Diana Stewart, who will be joining me in this last discussion here. The goal of this particular module is to highlight and describe Maryland state regulatory implications for medication management across the continuum of care, to discuss the federal regulations or FTAGs that exist relevant to medication management in the nursing home and the long-term care segment, and then to apply some of these concepts that we talk about. And we've talked about antipsychotics, but the principles can be applied to potentially other medications as well, but with a focus on antipsychotic use. So when we look at the state of Maryland in the context of pharmacy law, it's important to note that state law may differ from federal law, and also important to note that the more stringent law applies. So when we're looking at pharmacy services within nursing home, there are state-specific COMAR that looks at proper storage, security, preservation of medications, as well as the distribution and accountability system with some of the technology out there, such as the automated dispensing systems. And then in addition, the inventory and destruction of controlled dangerous substances, CDS. And as we continue on, we look at pharmacy law and in particular the packaging and labeling of medications, and there's very explicit requirements that need to be on a label of a medication. Additionally, the emergency drug kits, and there are implications on the storage, again, accountability, and ownership of emergency drug kits. And this really becomes an important context and discussion when we're talking about controlled drug substances and making sure we're avoiding diversion and what kind of systems do we have in place with some of our technology and programs out there. And that gets into the tracing and quality control of medication orders. And then the other thing, whether this, again, looking at federal or state laws, looking at the reporting of adverse drug reactions as we focus throughout this medication use process. Some of the recent attention given to concerns regarding opioid use or abuse and diversion throughout the state and throughout our country. And our state has a prescription drug monitoring program. And this particular program monitors the prescribing and dispensing of drugs that contain controlled drug substances, Schedules 2 through 5, dispensed to the patient and or their agent in Maryland. And again, this information, which is an ongoing current reporting system, must be reported no later than 3 business days after dispensing. And this is really helping to curb, hopefully, the abuse that's happening out there, again, across all practice settings. It really helps assist healthcare providers and enforcement agencies in reducing the non-medical use of CDS as well as the abuse and diversion. And it also preserves professional practice and legitimate patient access. I think many of us that are sitting here have been feeling in awkward situations when we're not really sure how often they're filling their medications, but with this drug monitoring program, we now have access to that in real time. You want to speak to that at all?
It really helps detect those patients who are doctor shopping, patients who go to multiple prescribers or, they go to emergency rooms and so forth. It's very helpful.
And I think especially in the setting of increased liability, which we're all practicing in now, this just makes people feel more comfortable. We always want to ensure that we're properly treating patients with legitimate pain, and this kind of helps us further differentiate who those patients are. That way we're treating the people who need treatment, but not enabling patients who are abusing and diverting these substances.
Great point. And when we continue on the prescription drug monitoring program, when we look at what's being reported, this information needs to be reported, again, in that timely fashion. So to continue on some specific state regulations that are relevant to the population in advanced illness, assisted living facilities are becoming more of a common place for older individuals to reside who need care because they really incorporate that social model. There's various settings out there, some small, some larger. But within the assisted living facility, in particular within the state of Maryland, every state has different regulations surrounding medication management and administration. I like to think the state of Maryland is a little progressive here. We actually have pharmacist mandated reviews to really look at polypharmacy and ensure appropriate medication use. But when we look at the administration of medications, another thing that is all staff who administer medications to residents shall have completed a medication administration course. So this is a training that's mandated for people that are giving medications. Because important to note, in assisted living facilities, these are not nurses. But they do have to have nurse oversight with a delegating nurse that comes in at least every 45 days. The assisted living manager needs to ensure that the resident's initial assessment process is looking at whether a resident is capable of administering their own medications, as also looking at the program to make sure that the medications are being stored properly or if assistance is needed. So again, medications need to be administered, stored, and there's a lot of really explicit regulations within the pharmacy law and in COMAR that really articulates that. But just wanted to highlight the medication oversight, the medication management aspects in assisted living facilities that are unique to Maryland. As we look at a national landscape and we focus in on these FTAGs, the FTAGs and the interpretive guidelines are found within the State Operations Manual, and in particular, looking at Appendix PP, the interpretive guidelines, you'll see the regulations categorized by the FTAGs. You'll see this interpretive guidelines, which helps us to understand things we should be looking at that are implied from the regulations. And then coupled with this are investigative protocols. In particular, some of the investigative protocols that have been combined are the unnecessary medications, which we're going to talk about, as well as the medication regimen review, F329 and 428. Coupled with that are severity, guidance, and deficiency categorization, which have implications in terms of fines, in terms of licensure within these facilities. So some of you may be very aware of this, and this is a great review. Others, this may be a little new to you, especially if you're not working in the long-term care nursing home segment. So again, when I look at the pharmacy or medication relevant tags with a focus, F329 focuses on unnecessary medications, 425 focuses on pharmaceutical services and procedures. So this is important when we're looking at those policies and procedures, looking at the medication use system. How do we look at e-kits? Who has access to things? How are we storing things? How are we disposing things? What are our policies and procedures here? Because one of the other areas we talked about in our previous module focused on infection control. So a lot of attention is given towards some of our programs in place to address that. F428 is focusing on that drug medication regimen review, and ideally the principles that Dr. McPherson talked about in terms of deprescribing and that looking at that risk benefit, that harm benefit is important here. And then, of course, some of the very explicit discussion on labeling, storage, including controlled medications that we'll talk a little bit about. I like to focus on the unnecessary medication regulation first because it gives us an overview. Again, reinforces many of the discussions that we've had earlier and the principles in terms of ensuring, is this medication necessary? I don't really love the word unnecessary, but it really comes from the Federal Register back in when this was developed in the 80s. But again, we want to ensure that a resident's medication regimen is free from any unnecessary or inappropriate medications. So when we're looking at this, we need to look at the context, excessive doses, looking at duplicative therapy. Sometimes it's justifiable to maybe be on two antihypertensive therapies, but again, if we're looking at liberalizing control and looking at patient goals being different, maybe it's not needed. Excessive duration. Sometimes patients are put on medications and it's not clear when they should be being stopped. This could be antimicrobials, it could be psychopharmacological medications. We talked a little bit about that with delirium. PPIs in terms of proton pump inhibitors. The other thing is looking at adequate monitoring. How often should we be monitoring? And I think this, is a discussion too, because sometimes it comes up to us, well, if I have a patient who's in hospice, who's still on levothyroxine, but I'm not checking their thyroid, what do you think about that, Dr. McPherson?
Well, often they ask us, should we just stop the drug?
Right.
No, you should not stop the drug.
No.
And if it's appropriate to monitor it, you still monitor it.
Right, because you're getting at symptomatic management.
Absolutely.
When patients' thyroid isn't well controlled, they might be more confused. They might be lethargic. It might impact their function. So again, it might be needed to monitor, but what is adequate monitoring? And that's really where it invokes the team discussion in terms of looking at that. In the presence of adverse consequences, which indicate the dose should be reduced or discontinued. So, we spoke a little bit earlier, Dr. Stewart, about delirium and the treatment of delirium, and you so nicely stated benzodiazepines, right?
Oh, absolutely. So let's say a patient is receiving benzodiazepines for the management of anxiety. If they develop delirium, that would be a good time to review the medication profile, and maybe that drug is not only no longer beneficial, but in that situation harmful.
Right. Absolutely. So looking at that presence of an adverse consequences, we used to call them red flags, change in mental status, new increased falls, delirium. Let's look at the medications. Any new symptom in an older adult, right, should be considered a drug side effect until proven otherwise. So the principles within the F329, and even if you look at the interpretive guidance to date, really focuses on looking at medications in the context of care process. So something I'm really passionate about, as you can tell. So when we look at within particular, because we said within this module we'd focus on antipsychotics. So antipsychotics, again, you need to have a comprehensive assessment of a resident, right? Whether that residence in, chronic care management, palliative care, hospice care, a comprehensive assessment, because the facility must ensure that residents who have not used antipsychotic drugs are not given these drugs unless there's a necessary specific condition that we need to give these medications, right? And residents who use antipsychotic drugs, if they come and you come into a facility on them, that they receive a gradual dose reduction as well as behavioral interventions, unless there's clinical contraindications to not do that, to really reevaluate are these medications still being needed. And there's a lot of concern regarding antipsychotics in the perception of them being used as chemical restraints. And so it's been a class historically when we look at OBRA and we look at kind of changes through time, but still the perception out there regarding the judicious use of antipsychotics. So let's talk about that in the context of pain management, clinical considerations, with F329, and this is not just focusing on antipsychotics, but analgesics. So, Lynn, do you want to kind of walk us through a little bit when we talk about some of those contexts of using and addressing pain management with this tag?
Sure. So when you're considering using acetaminophen, for example, obviously the type of pain, it's not going to help neuropathic pain at all. You might as well give them peanut M&Ms for all the good that it will do. So it has to also be pretty much mild to moderate pain. It's not a medication for severe pain. Even for osteoarthritis of the knees, for example, it's barely better than placebo. If you do decide it's an appropriate drug to try, you want to respect the dose limits. We say 3 grams over the counter, 4 grams per the FDA if it's recommended by a prescriber. So you do want to respect that. And acetaminophen is in so many combination medications. You have to consider all your potential sources. It's so important to assess the pain, both baseline before you start medication therapy and then on a regular basis afterwards. Minimally, a pain scale which looks at the severity. I do like a multidimensional scale, so when you're looking at setting goals, it's not only the patient's pain rating, it's also their functional status. So to ask the patient, what would you like to be able to do that the pain keeps you from doing? So it's fine to say the patient says I want the pain to be a 4 or less on a 0 to 10 scale, but another goal may be, and I'd like to go to eating together in the dining room instead of having my meals in my room so I can socialize, or to be able to ambulate to the great space, the great room, so I can watch TV with my friends. And you always want to monitor the adverse effects. So Dr. Stewart talked about the 5 A's. This is the A of adverse effects, very important. So you have to consider the whole picture. Is the drug appropriate? Is it the right dose? Are we monitoring it for both efficacy and toxicity?
Fantastic. Great. And then as we continue in some of the other regulations within the FTAGs, F425 Pharmaceutical Services and Procedures Regulation Overview, again, ensuring timely available medications to meet the residents' needs. And in this particular guidance, interpretive guidance, they state the facility is responsible for employing or contracting for the services of a pharmacist to provide consultation on all aspects of pharmaceutical services. And that is just what we talked about, the medication use process, to make sure that there's a good program in place, that we're overseeing that, we're ensuring safety along all those various steps of care. oftentimes 329 gets coupled with 428, and this explicitly states that the drug regimen of each resident must be reviewed at least once a month by a licensed pharmacist. And the pharmacist then must report these irregularities to the attending physician and the director of nursing, and these reports must be acted upon. And I can tell you, I work in many practice settings outside of just skilled nursing facilities, whether that's an assisted living facility or in the community, and I love the statement that they must be acted upon, because that means someone's taking attention to the things that we've identified. So hopefully completing that loop, and with the advantages to improvement in technology, hopefully we'll have better, more timely communication. And then last but not least, focusing on storage, labeling, controlled medication regulation overviews. Again, we talked a little bit about the monitoring plan within the state, but this is on a national level, saying that each facility must, again, obtain the services of a licensed pharmacist who establishes a system of records of receipt and disposition of all controlled medications in sufficient detail to enable an accurate reconciliation. Again, getting at other tactics to improve medication use accountability and also to reduce diversion. And they must be kept in an orderly account and periodically reconciled. And audits are going on day in and day out, looking at how are we ensuring that medications such as our opiates are not being diverted. So I'm going to come back to antipsychotics. We jumped on that a little bit in terms of understanding it within the context of F329, but there has been continued attention being given to antipsychotic use because of its off-label use. And unfortunately, in some of our patient populations, those with dementia, there's a black box warning in terms of the safety and increased risk with death and morbidity and mortality. So again, attention, the black box warnings, the 2012, the 2015 Beers criteria continues to bring attention to that. The Centers for Medicare and Medicaid Services put out a national initiative to reduce antipsychotic prescribing to nursing home residents. This initiative has then rippled its way through other quality metrics within Medicare Part D and people being scrutinized on their prescribing. We talked a little bit about quetiapine and its use being off-label for sleep, but looking at that safety. So what we're seeing is that surveyors are coming out looking at the principles within F329. And so when you're looking at antipsychotics or other medication that are high risk, looking at factors such as what is the indication for use. So we just talked, and I'm deferring to my faculty here, we just talked about antipsychotics being used for the treatment of delirium. We just talked about antipsychotics potentially being used for helping our patients with nausea, vomiting. We talk about it in approved indications that we know in terms of schizoaffective and schizophrenia, which mental illness in long-term care facilities is on the rise, with patients no longer living in acute psychiatric facilities. So understanding the indication for use, understanding the dose, and maybe the lower doses being used versus the higher doses, and then the duration. So do you want to speak to that a little bit? Because I know there's sometimes misperceptions out there regarding how surveyors are looking at antipsychotics across the
So where do you
nursing
think
homes.
the deficit is? Is it on the part of the prescriber or the nurse, for example, working in the facility?
I think it's just as we talked about the medication use process, I think there's multiple deficits out there. I think that sometimes there's a lack of clarity of why we're using these medications. They're coming out of an acute care setting where they might have been delirious or the delirium's resolving. I've actually started to see put on antipsychotic orders discontinue after 2 weeks. So they're actually putting a duration of care. Now that may not or may not be necessarily appropriate, right?
But I actually did
Yeah.
that when I was working in the ICU because we would start these medications for delirium. And the concern is maybe once you leave for the day, the patient might transition to an intermediate care facility or a rehab facility, and you don't get the chance to do a comprehensive medication reconciliation. And another common culprit are the proton pump inhibitors for the prevention of gastrointestinal bleeding in the ICU, and you see those continued all the time without true indications. But I think the quote you mentioned in part one of this module about changing systems is really the key here. If we don't have access to electronic health records and electronic documentation that are accessible throughout different systems, it's very difficult for people to really keep on top of all of this.
Absolutely. And I think, oftentimes the prescriber downstream as we talk about maybe some of the factors here, the prescriber downstream doesn't always feel comfortable about stopping something upstream that they didn't start because they weren't really clear what the indication for use was.
So maybe
Yeah.
you could give us a little guidance on
Sure.
what can the hospice nurse do who's providing care for a patient in a long-term care facility who has this very frightening delirium, or they're very nauseated and they want to use an antipsychotic like haloperidol. What guidance can the hospice nurse give the long-term care nurse? Because many times it's the hospice physician who can order the medication, such that the long-term care nurse can do his or her job and document appropriately to meet the letter of the law.
So the key thing, right, as you stated, is you were giving us what the clear indication for use, and then you were giving us monitoring parameters to really look at effectiveness. So I think if you can give clarity to the care staff, whether that's the nursing staff who's giving the medication, the care staff of what we're hoping that this medication is going to improve, because in the absence of understanding an indication for use, things, we call them the diagnosis creep. You know, things get added and it's not really clear. You know, it's something like for agitation when that wasn't the intent of the medication, right? So I think having a clarity and then really looking to see, does this medication help?
So would you expect the long-term care nurse to document patient is free of nausea every single shift?
Well, you know, when we talk about monitoring, what's realistic? You know, I think we have to be cognizant, you know, is it every shift, if that's the way in which we're going to look at the effectiveness of the medication, and you've got staff that can look every shift to do that. Sometimes, though, in some settings, especially maybe assisted living facilities, they don't have maybe as much shift involved. So maybe once a day is more realistic. So I think to be conscientious of how long, as you talked about earlier, the scopolamine takes 12 hours to work. But people sometimes expect an instantaneous benefit and then it becomes a failure and they want something else right away.
So appropriate and consistent documentation
You
is the
got
answer.
it.
Got
Yeah.
it.
And I think sustainable, right? I think sometimes we put programs in place that are just not sustainable, especially with policies and procedures. So when we look at generally indicated for these conditions, again, outside the scope of dementia where it's an off-label use, you'll see some of these conditions. So as we've talked about, the nausea, vomiting associated with cancer, chemotherapy, or maybe other conditions as well, besides just those two. We try to give a general sense. But one of the concerns, which sometimes can be a red flag for surveyors and for others, is when they start using these medications for things such as being uncooperative, not sleeping as well, poor self-care, and again, addressing that. So when we look at appropriateness of use, the diagnosis alone does not warrant the need for a medication, okay? But again, some of the consideration, if they're using it for dementia-related behaviors, that these behavioral symptoms present a danger to them or others around them. And the symptoms are due to mania or psychosis, where the target symptoms do respond to antipsychotics. And it's imperative that we look at other things besides drugs in the plan of care, and there's a lot of focus on non-pharmacologic interventions. So again, when we look at this and we look at definitions, we look at symptoms, we look at, you know, and that's the indication or characteristic of a physical or psychological condition. The other concern, though, is the perception of these medications for chemical restraints, and that's any drug that's used for discipline or convenience and not required to treat a medical symptom. And specifically within looking at the state of Maryland here, looking at use of psychopharmacological medications and chemical restraints, and this is coming out of our COMAR. Again, a lot of concern, and that's why there's been a lot of attention. So when we look at it from a regulatory perspective, I think Dr. McPherson, we kind of just alluded to this a little bit already. You know, so a patient's on an antipsychotic in palliative care or hospice care, what are we using it for? Are there safer alternatives? Should we have been trying that on Dancitron, or do they really need to be on haloperidol, right? But I'm just saying it out there because I see more and more on Dancitron being used, but it may not be really effective.
You know, and that's what kills me
Yeah.
because it is not targeted therapy. It's hugely more expensive, and you're trying medication that's not without side effects also,
Absolutely.
all because of the fear of this regulation. When half of a milligram of Haldol would fix it.
And if we have a clear understanding of why we're giving it and the expectation to be used and how long we're using it for, that's justifiable. And I think we have to overcome the antipsychotic that they're all bad, because the roles is about judicious use of these medications. And so when we look at this in the context of F329, again, gradual dose reductions if they've been on a period of time. We had a patient on stelazine that we just saw presenting with cognitive decline, and as we know, not only is he on the stelazine, the trifluoroperazine, but he's also on benztropine because of that agent. And so can we gradually reduce to get rid of some of those other medications and continued need in the context of looking at gradual dose reductions? And again, this just gives you context, because I think the principle of gradual dose reduction is one we need to use across other prescribing settings. And so we traditionally look at this in the context of nursing homes, but these same principles, just as you talked about deprescribing, it's getting at the same philosophy.
But when you look at hospice, our average length of stay is 21 days.
Right.
So to talk about attempting a dose reduction within a year is kind of a moot point.
It is a moot point, but we talked about this in the span of not just hospice care but palliative care.
Sure.
So looking at that in terms of what are we trying to treat here. And so it gets a little bit more in terms of contraindications. So some of this, again, looking at the target symptoms, looking at the diagnosis, clearly explaining why we're using it and monitoring our patients over time. And I just like to spend a moment, because this is something that's going on in terms of in a partnership to improve dementia care. And as we said, Alzheimer's disease, dementia is one of our common conditions that we're seeing. So there's a lot of activity being focused on a national way from a regulatory perspective, from an educational perspective, from a stakeholder perspective, and then of course from a public reporting perspective. So this is again looking at the antipsychotic use, and so our facilities are often asking us, okay, where do we compare to others? So just to give you that perspective as well. So with that, if you really want to learn more, there's a lot more information out there, and here's some additional resources. So at this time, I'd like to close the medication management in patients with advanced illness, and thank you for your participation.
And Dr. Diana Stewart and I also thank you for your participation, and we hope you've enjoyed the course.